Hello, everybody, and welcome to the second Faculty Development webinar by the Faculty Development Committee of the College of Family Physicians of Canada. The slides will be bilingual, and but the French questions can be answered in French by me, your Francophone presenter. Some instructions to begin with. To participate in the live chat, please log into your YouTube or Google account, and to participate in polls or ask questions, you have to go to the Poll Everywhere site using the link on the slide. This live webinar has been certified by the CFPC for one Main Pro Plus credit. Please complete the evaluation survey. The link will be in the chat box for direct credit entry of Main Pro Plus credit. And after this live event, a recording of the webinar will be available for viewing, but will not be eligible for Main Pro Plus credits. We would like to acknowledge all the members of the Faculty Development Committee who have participated in the creation of this webinar, as well as the team at the college for their logistic support. And I am Dr. Lynn Ménard, Assistant Chair for Faculty Affairs in the Family and Emergency Medicine Department at the University of Montreal, and member of the Faculty Development Committee at the college. And I will let my colleague introduce herself.
Thanks, Lynn. I'm Vina Broderick. I'm an assistant professor and family physician at Memorial University of Newfoundland, and happy to be here today, and thanks for joining us.
And we have to say that neither of us has any conflict of interest to declare, and the webinar program has received support from the college in the form of logistic assistance. And this is the same slide in French, so nous n'avons aucun conflit d'intérêt à déclarer. Should you want to comment on social media, the CFPC is on Twitter, Instagram, and Facebook, and you can use the following hashtags, hashtag FM Teaching or hashtag Enseigner la MF in French. Now, here's our menu for today. For the first course, after the first course, you'll be able to describe the principles of effective learner-centered feedback. After the second course, or the entrée, you'll be able to outline how to apply feedback principles to family medicine. And after the third course, you'll be able to prepare learners to receive feedback. And if there is time for dessert, you will be able to facilitate learners' use of feedback for improvement. And now, let's start with the first course.
Okay.
Here's to you.
So I get to talk about the appetizer. But before I do, just a couple of quick words. Providing feedback is really a key tool that we use in clinical teaching, but it's not the only tool. Other things like preparing the learner, orienting them, and observing them, and so on, are also really important. So some of these have been discussed in our previous webinar, and I'd like to refer you back to that. Also, that clinical teaching is so fast-paced and at times chaotic. We can all agree to that, I'm sure, where we're doing so many things at the same time. So, there's little time for teaching and providing feedback. So we hope to provide some tips for you today to help you in doing that. So we'll move on to what we've got our first case. All right, so you're working with Connor, a first-year family medicine resident, and he's the first learner you've had since setting up your community practice 1 year ago. So you're a new preceptor. He's just seen one of your patients, Mrs. Brown, and has presented the case to you. You want to give him feedback, but you pause, wondering how best to do that. So we'll give you a few moments to answer that poll question. So Lynn, how comfortable are you at providing feedback?
Well, I think that when I first began my career, I was quite uncomfortable. Back then, I was almost the same age as the residents, so it was quite difficult. Mm-hmm. They felt more like friends, so having to be critical to friends or peers is a bit hard. But as I gained experience, I got more and more comfortable with it. And now I really understand that it's something that's part of the teaching. It's something you have to do. It's your role. If you're not there to guide them to improve, then you've not done your job properly.
Exactly. I guess some other issues that we see are, time pressures. Things like relationship with the learner. I'm sure that there are many reasons why people may or may not feel comfortable giving feedback. And so we hope to cover some of these in our presentation today. So we're looking at our poll as it's coming in. And so we've got somewhat comfortable to very comfortable. So this is great. So
hopefully we can make you even more comfortable.
Exactly. We may be able to give you a few other tools to put in your toolbox.
Okay. So
great.
Let's move on.
Great. So let's move on to the definition of feedback. So there are many definitions of feedback out there available in the literature. This is one that I thought was kind of succinct and appropriate. It's the sharing of information on actual performance to help guide the student's future performance towards a desired goal. So we also have to remember that this is, I guess, in the era of competency-based education, so providing feedback is even more important. It truly is the cornerstone of effective clinical teaching and a critical component of effective learning in clinical situations. It really is essential to learning. And the purpose of giving feedback is to encourage the learners to think about their performance, how they can improve, and have them reflect on what they're doing and try to narrow that gap between kind of actual and desired performance. So really it requires a sample behavior, a clear model of the desired behavior, and a demonstration of the difference between those two. So really it's a skill, and like any skill, it can be learned and improved through preparation, practice, and using a systematic approach. So I've said it's important and that it's essential to learning. I think most of us as preceptors, as teachers, feel that we do give regular and sufficient feedback to our learners, but the literature actually contradicts that a little bit, that learners feel that we don't always give them either regular or sufficient feedback. And there are many reasons for this, and we'll discuss a few of these. So now let's look at the different types of feedback. So first I'll say that feedback and assessment and evaluation are really quite closely related in educational activities. So it's quite important to distinguish between the two. So we talk about formative feedback, which is providing feedback to inform change and improve student learning and performance. So it's about presenting information, not about forming a judgment. So we're trying to inform change and improve student learning and performance. Again, it's a fundamental part of the learning process, and it's intended to help the learner attain their goals. It's composed of neutral and non-judgmental statements. So we as teachers need to kind of reflect on that. And an example of this would be field notes, written feedback notes, versus summative feedback, which is more of a judgment of an overall performance, often in relation to their peers, so things like ITERs, all right? So feedback is most useful when it's provided as a formative feedback. Another way to look at feedback, or another, I guess, framework, is what the intended purpose for the feedback is. So is it for reassurance, what worked well? Is it for benchmarking, how the learner's progressing compared to their peers? Or is it for performance improvement, what they need to focus on to improve? So it's another way for us to think about it. All right, so now we're going to move on to the feedback ingredients, and on the theme of our menu, we've got 5 feedback ingredients here. And again, before I get into the specifics, I want to mention that giving effective feedback is best when the teacher and the learner work together as allies and have a common goal. So it's important to establish trust and work in an environment where there's support and respect. And we're going to talk a little bit more about that as we talk about preparing the learner to receive feedback. But it's best if it's an everyday normal component of the teacher-student relationship, so that both sides can expect it and manage it. And as I say, we'll be talking a little bit more about that as we go along. So if we look at the feedback ingredients, this list of ingredients was taken from a handout that's provided by the College of Family Physicians, developed by residents for residents, but can be applied to any learner. And it's titled Effective Feedback Handout for Residents, and it's on the CFPC website. You can see a copy of it there. So these are the principles of learner-centered feedback. So we'll start off with number 1, immediate. So it's a dish served warm. I guess that ties into our menu theme, our appetizer theme. So it's all about place and timing. So it should be timely. Everyone should remember the details. It should be observed by the preceptor, by the teacher. However, if for some reason you can't review that feedback with the learner at that moment because it's an emergency situation or so on, it can be delayed. But as soon as possible after the encounter is recommended. So immediate. Number 2 is specific and relevant to the task or the situation. So a useful way to provide feedback is to think of things like what was done well. So what did they do very well? What could be improved? And what to do the next time and if this situation was to come up. The things that we want to avoid are generalizations. The more specific, the better. Comments like, keep up the good work. I mean, we've heard all of these. These are very common things, as I'm sure as we as learners heard. Mm-hmm. Progressing well, no concerns, friendly, punctual, easy to teach. While they're very nice statements, they really don't give the learner any specific feedback. So, we want to try to make sure that we're being as specific as we can. We also want to focus on modifiable behaviors, on decisions and actions, not on our assumed interpretation of that. And things like personality traits, unless they're manifested as behaviors, really aren't appropriate for feedback. So that's being specific. The third is case-based. So the feedback should relate to a specific case or situation, encounter with a patient, or perhaps speaking with a colleague or a pharmacist on the phone, those kinds of things. They should also be, number 4, competency-based. They should be centered around the core competencies in family medicine, that is the 99 core topics, or if this is an undergraduate situation, then they should be centered around the objectives for that program. And number 5, they should be objective and concise. They should be accurate and to the point. I would also add that, again, it should be part of the normal everyday interaction. There should be the use of non-judgmental language and making sure that the criteria against what the student will be assessed is known, and focus on no more than 2 to 3 key points. The learner should understand the feedback and should have input into the feedback, into the development, and and that it should be balanced, seeking the learner's perceptions about what happened. All right, so those are the key ingredients of good feedback. So what is it that stops us, or what are the barriers to good feedback? As the webinar progresses, we're going to learn a little bit more about all of these. But basically, providing constructive feedback it can be a very difficult task. And most of us receive little to no training in giving feedback. And some teachers may feel that it may actually damage the relationship with learners, and so they don't want to undermine find their self-esteem. Constructive feedback can be awkward to give, and you may want to avoid looking critical in front of peers and colleagues. There are other issues like cultural context issues, hierarchy issues between the teacher and the learner, as well as the student's ability to self-assess. If we make no comment to the learner, they may assume that all is well, and they may have to rely on others for their feedback, or may have to guess at the level of their competence, which we really don't want them to do, based on how they're coping. They may have to learn by trial and error also at the expense of the patient. So, we want to give feedback. We want to, confirm good performance, reinforce it, and so on. Okay, so how do we give feedback? So there are many models. I think as long as you use a systematic approach, a lot of these are very appropriate and very useful. We'll be reviewing these in particular, not in any great detail, but we'll give you some tips for when to use them and the limitations that they may have. So we'll start off with talking about the feedback sandwich. So you can go to the next slide. Sorry, no, just the next.
Sorry.
Okay, so you've probably already heard of this method. Most of us have used this, or it has been used on us. Basically, you're providing a reflective statement or a positive statement, then a corrective statement, and then a reinforcing statement. So actually, that should say corrective statement, not positive statement, down in the second line there. So an example of this would be if you were with a learner and you were watching them examining a patient's liver, that you say, I liked the way you palpated that patient's liver edge. Your technique was really good. Then you say, but I noticed you didn't look at your patient to see if the patient had any discomfort while you were examining them. And then you might follow up with, your summary of findings was also well done. So I think we all understand what the common sort of mistake here is, that the word but before the final positive statement, the students anticipate that, and they kind of shut down and don't quite remember or acknowledge the positive statements. So this type of feedback, there is a little bit of imbalance, that it's primarily focuses on the teacher. So as I say, it's one that we all have had experience with. It may not always be the best way to provide effective feedback, because feedback needs to be a conversation between the teacher and the learner. It's about performance rather than it's about performance rather. It's a two-way conversation, not a one-way conversation. And learners need to be able to and are encouraged to express their own views when we're discussing feedback, and this doesn't give them a lot of opportunity to do that. I do mention this because, again, it is commonly used, and it's not a bad technique, but I hope to offer you some suggestions for some other models that you may find as or more helpful. So we'll move on to the 1-minute preceptor. It's also referred to as the 5 steps microskills module, or in a lot of the literature about teaching on the fly. It's meant to be brief. It's called the 1-minute preceptor, so it's supposed to be 1 minute. It can stretch out to 2 to 3 minutes sometimes. It was first described in 1992 by Nair and colleagues, and it's really an alternative to the traditional way of precepting. So that by the traditional way, those of us that trained perhaps years ago, you came out, you gave your story, there was no question asked of you in terms of clinical reasoning and so on, and you went back in with your preceptor and went through the history and physical again, and then you came to your conclusions. So that that's great for diagnosing the patient, but it really leaves the learner out in this picture. So the 1-minute preceptor gives us as teachers a method to facilitate the learner's presentation, look at their thought process, and then for the preceptor to provide targeted teaching points. So it really helps the learner and the patient. It's good for the learners to practice their clinical reasoning. I think that that's really the benefit of this model. The next model is called the SNAPS model, and this also, tests or discusses clinical reasoning, but maybe in a slightly different way. That is the the 1 minute preceptor. So if we could go back to the 1 minute preceptor for a moment, because I just want to end next. Thank you. So the 1 minute preceptor consists of 5 steps. So the first one is getting a commitment. So this can involve any aspect of the case, so either diagnosis, treatment, follow-up. The learner should be challenged to make a commitment at this stage. So questions like, what do you think is going on? What investigations do you feel are indicated? And what do you think will be accomplished by this visit? So really kind of, drilling it down and asking them to give that commitment. That's important. The second step is to probe for supporting evidence. So after you've heard this and they've made their commitment, so what are the major findings that led you to this conclusion is one question you could ask. What else would you consider? And what made you change, that particular point of view or choose that treatment? Number 3 is to provide general rules. So you're going to keep it brief and you're going to focus on the identified issue at hand. Number 4 is to reinforce what was done correctly. And you're going to be very specific in this stage of the process. And number 5 is to correct mistakes. So steps 1 and 2 bring into light the learner's needs, and then we can provide with them personalized teaching. It's actually a very efficient model for giving feedback, and may lead us to teach about more disease-specific points and differential diagnosis. And most teachers feel better prepared to assess learners' needs when they've provided us the feedback the case in this way. It's usually pretty quickly learned and easily implemented as well, and there is a built-in mechanism for feedback in this. Okay, so we're going to go on now and talk about the SNAPS model, just briefly. We'll mention this because some of our preceptors may already be using the 1 minute preceptor as just an alternative. It's maybe, it's a bit for more the advanced or motivated learners. It takes a little bit more time. It requires both the preceptor and the learner to use the framework, to learn the framework. The teaching encounter is mostly learner-driven, though. So the learner presents the case, directs the discussion to the differential. The preceptor doesn't really have a role until about step 4, where the learner asks questions. But even then, the discussion is still quite learner-driven. So as you can see, number 1, summarizing briefly the history and findings. Number 2, narrowing the differential to 2 or 3 possibilities. 3, analyzing the differential. 4, probing the preceptor by asking questions. 5, planning the management. And 6, in the 6th step, this is quite an interesting step, I think, the final step. You pick a case-related issue to examine, and you send the learner off with a little bit of homework to do that. So this encourages the learner to progress and, kind of extends it beyond the learning encounter. There's no specific spot here for feedback in the model, so you need to kind of focus in on step 4 when you are, trying to, I guess, give them feedback. And oftentimes it's paired with uncertainty at this step in the program, in the model, and it focuses on the learner's immediate needs. Okay, and finally we'll talk about the R2C2 method, which was developed by Dr. Joan Sargent and her group. This model presents a different approach from the traditional ways of giving feedback. It helps emphasize that the goal is really to help the learner to change and improve, and engaging the learner in reflective conversation about the feedback and how they can improve. So there's 4 stages. The model is intuitive, especially within the competency-based education. It's easy to follow as well. The time commitment is a bit longer than with some of the other methods we've talked about, but it is especially excellent at building rapport, relationships with our learners, things like, tell me how things are going. What was your last rotation for step 1, step 2? After they've received their feedback, how did you think things went? How did these evaluations compare to other rotations? Number 3, content. Is there anything you want to focus on? And number 4, coaching for change. Might be something that they want as a goal. So this is also a very interesting and important feedback model. There's one other, or several other, that I'll mention just very briefly. One called the Bayer Institute Grid, and I wasn't as familiar with this one, but I did do a little bit of research, and this too looked very interesting, where you're focusing on behaviors to continue, to do more of, to start doing, to stop or do less of. So I think as long as you choose a method and use a systematic approach, this will help you in your providing feedback to your learners. Okay, so just a short word about self-assessment and how it relates to feedback. There's a phenomenon that perhaps some of you have heard of called the Dunning-Kruger effect. It's a type of cognitive bias in which people believe that they are smarter and more capable than they are. So what he's describing is, say, for example, someone who has low ability, but they don't have the skills to recognize that, and that combination of poor self-awareness and low cognitive ability can sometimes lead to situations where it's so important for us to provide this feedback to the learner. Otherwise, they really don't know what they don't know sometimes. And most of us, that's true. We don't see ourselves as others see us. So we as the teachers need to be there to provide that kind of feedback for our learners. So that's a lot of information there about all the different models and things, and I'll refer our teachers to the CFPC website under the Faculty Development FTA Framework website, that they can find more information about these methods and the things that I've discussed. There's also a very helpful feedback card that's provided by University of Toronto, which I found to be quite helpful and very succinct, and it's a pocket card so that learners can carry it and the preceptors can use it as well.
Okay, and now for our second course. And thank you, Vina, for that nice appetizer, which was a big plate to share, I think.
Absolutely. It's for the family.
It's a family type. So the second course is the entree. And this is our question poll. From the 7 CanMeds FM roles, which are communicator, collaborator, medical expert, leader, health advocate, scholar, and professional, how many roles do you actually regularly give feedback on? So we're waiting for your answers, and I'm going to ask Vina, what about you?
I guess primarily it would be the medical expert, as we've been discussing right now. That seems to be the main role we give our learners. Certainly, we try to promote health advocacy as well. We, in our practice, have a large refugee, new Canadian practice. So that's an important part of our practice, and it's a place that we talk, as well as in our regular clinic, but certainly talk a lot about health advocacy. How about you?
Well, I guess it depends on your own focus. Sometimes you develop skills in collaboration or communication. That's what you will give feedback on mainly. But very often it's the expertise role we're comfortable with. So that's very often the one we give feedback on. Okay, so I guess we're having quite a few experienced teacher in our audience because I see a whole lot of 3 or 4 roles being given feedback on. So that's quite good. Quite good. So here's our case. You just reviewed Mrs. G's case with ACE, which is a first-year resident. He's just seen Mrs. G. She's a 72-year-old widow who lives alone and had a recent fall in the bathroom with minor bruises. During the review, AC demonstrated good knowledge about the causes of falls in the elderly, and he also recognized Mrs. G's desire to remain independent at home, so he initiated a referral for a fall assessment with the home care team. When he's asked about other healthcare providers involved in home care that could be helpful, he didn't know about physiotherapists or occupational therapists and what were their specific roles or what was the difference between those 2 roles. So, with that case, how would we decide which CanMed's FM roles are going to be the focus of our teaching session? Well, the way to decide what to focus on during a teaching session depends on the needs of the learners, basically. And the needs of the learners, they can be perceived. They're rarely expressed spontaneously. Well, that's a hard word by the learner. But you can ask the learner what role they want feedback on. It can also be determined from a previous encounter because of something you observed or after a feedback discussion with your learner. Maybe it's one of your colleagues that noticed something and you want to pay attention to this. Or maybe a patient made a commentary that you want to on a learner's previous performance. The needs can also be normative. Those are the ones that are competency and objectives to be achieved by the program. If some of you attended our first webinar, you might remember we discussed the importance of orienting the learner to your practice, stating your expectations, and exploring your learner's objectives and knowing the rotation's objectives. Taking the time to do this will make will help you choose the angle of your supervision and make feedback easier. And when I say we talk about being opportunistic, that means seizing the occasion. So based on what type of patients you have that day or what you happen to observe. But then one has to be careful not to limit themselves to expertise again. But sometimes, even if you choose to focus your supervision on a specific angle, that sometimes a critical event occurs and you have to address this, so you change your angle. That's what I mean about being opportunistic. Mm-hmm. Now, if we go back to Mrs. G's case, what CanMed's FM role can be highlighted in this patient encounters? Well, the first one that comes to mind spontaneously is the expert role. Got that one right. Mm-hmm. But in that scenario, the preceptor could choose to give feedback on at least 2 other roles. The learner in the vignette seemed to have a good contact with the patient and integrated her perspective in the care of the plant. She wants to stay independent at home. So this could be reflected to the learner as good communication skills that he or she should keep doing. For the collaborator role, the teacher can give positive feedback on the initiative to involve the home care team for falls assessment and some constructive feedback on the need to learn about the roles of other professionals, and maybe offer to organize a meeting with them as a follow-up plan for the learner. Home care setting in a family medicine offers a unique opportunity to highlight the collaborator role and also to help our learners understand how to access healthcare professionals outside of the hospital setting. Now, let's explore some of the possibilities for feedback that those 2 CanMed's FM role offer. So we're going outside of the vignette. If you choose to focus your observation and feedback on the communicator role, well, look for attitudes in your learner that could foster or hinder relationship with the patients or family or with the patient or patient's family and caregivers? Are they showing rigidity or prejudice? Do they seem impervious to the patient's feeling or story? Do they demonstrate adequate listening skills? Are they showing empathy and respect? Do they seem open, welcoming? Are they making eye contact or always looking at the paper chart or the EMR screen? And what about their interviewing skills? Is the interview well organized or going everywhere, jumping from one subject to the other without any logic? Can you follow easily? Does it flow like a conversation or is it more like a stereotype questionnaire? When you look at the chart, the prescriptions and other written communications, are they clear? Is all the required information included so that other doctors or professionals will understand the case and the learner's reasoning so that the transmission of information contributes to patient safety? On these slides, you can see links to the evaluation objectives defining competence for the purpose of certification by the College of Family Physicians of Canada. This document includes observable behaviors, which can help you a lot, both to know what to look for and how to phrase your feedback. And it's available both in French and English. For the collaborator role, the Health Professional Educator Group of the CFPC have put together tools to help teach and assess the collaborator role that can be found on the CFPC website via the link on the slide. And they came up with the acronym TEAMS to help teachers remember what to look for and give feedback on. In French, the acronym is EQUIPE. So in TEAMS, the T stands for thinking collaboratively. Now, does the learner consider the roles of the patient and other healthcare providers in all aspects of care and demonstrate patient-centered approach? The E is for engages others and encourages collaborative process. Do they seek and invite patient and other healthcare provider to participate in care? And do the learners value the different perspectives and expertise they provide? And do they actively contribute their own knowledge and skills? The A stands for assesses needs and resources. So do the learner recognize and reflect on personal and team members' strengths and needs in context and recognizes and reflects on patient care needs and strengths? Are they able to identify who in the team or which resource can best respond to the patient's need in this specific context? The M stands for manages and merges, and that's when the learner is able to integrate patient and family needs and wants, the healthcare team expertise, and the best evidence to manage the patient care. And the S, finally, stands for surveys outcome. Are they able to self-evaluate and review and reflect on the patient outcomes and the collaborative process to continuously improve? Now, we don't have the time in this 1-hour webinar to explore in detail each of the CanMed's role, but you could also choose to focus your observation and feedback on one of the other CanMed's role: leader, health advocate, scholar, or professional. The documents from the CFPC on CanMed's FM and CanMed's FMU, the U being for undergraduate, can help you find out what to look for, what is expected in each of these roles, and find the right words to phrase your feedback. Here's a few examples. If you wanted to give feedback on the leader role, that feedback could be around time management. If you want to give feedback on scholar role, it could be on self-learning skills and the ability to find the appropriate information. If you want to give feedback on the advocate role, it could be that the social determinants of health were taken or not taken in consideration in the evaluation of a patient. And feedback on the professional role could be on the ability to admit his own mistakes. And now, back to Vina.
Okay. All right, so for our third course, we're going to talk about preparing the learner to receive feedback. So first we're going to watch a little brief video.
Yep.
And this is...
No.
Oh, I'm sorry. We're going to have our poll question first. So how do you feel about receiving feedback yourself? So we're going to give you a couple minutes to answer that.
Okay.
Great. And how do you feel about receiving feedback?
Well, it depends on how it's presented.
Yes.
Sometimes it can be quite uncomfortable. I remember one time when after I gave a quite difficult feedback to a learner that he turned around and said, "Okay, now's your time, doctor. I'm giving you feedback." That one I really was not comfortable with.
How did you feel?
Almost threatened. But if it's brought like, would you like feedback?
Yes, yeah.
Or if sometimes I ask them myself, I'd like to know how this is going, and sometimes that's a lot easier if I'm the one asking for feedback. Then it's much easier to take.
Absolutely.
But it can be quite uncomfortable.
And it's a skill again. I think that there are ways to do it that are perhaps a little better, if I could use that word, the kind of language and things. So we're seeing from our poll here that most of you out there are somewhat comfortable. There are some that are uncomfortable. I see that there's no one who's very uncomfortable. So. And then there are some, the proportion is about 50% somewhat comfortable, and the rest is split between uncomfortable and very comfortable. Sorry.
So we can understand that our learners can be uncomfortable.
Absolutely. And you as a learner may remember what it felt like when you received feedback as well.
Definitely.
So now we're going to show you the little video.
See a little video.
This... Okay, so we've got a little case here. You're a preceptor who's meeting with your fourth-year medical student, Victoria, for the first time before she starts her rotation with you. And learners have a lot. We have a lot to prepare when learners come with us, but learners too have a lot to think about and to prepare. As you can see in the little video there, AJ has lots of things to think about, direct observation and feedback forms and things like that. So again, we're going to go back to some of the things I've already discussed, that feedback should be viewed as a normal part of the everyday component of the working relationship, and should be in the basis of having a supportive learning environment. And the R2C2 method is actually quite useful and helpful in this area because it's all about building relationships and trust. Yep. So confirming that the learner is actually ready to receive feedback. So a statement like, do you want to receive some feedback now on this, or after you've done this next task, or just, the timing, I guess, as we talked about earlier, to confirm with the resident that they're ready to receive it. Then you're going to want to make sure that you have enough time, space, and privacy if you need to give the feedback to the learner. Again, asking things like, is it a good time to chat now? Maybe after clinic, but making a plan and kind of following through to provide the feedback to the learner. So time and space are really important. If you're in the middle of a busy emergency department, that may not be the best time to provide constructive feedback to the resident or learner. You may want to take them aside to do that. Also to label as feedback. Many times in what I've read in the literature, we give feedback, we tell the learners how they're doing. I think unless we actually, sometimes if we label it as, I'm now giving you feedback, so I'm going to give you feedback, then this is feedback, and I'm going to write the feedback down, is what we do now with field notes. So I think it's important to label it so that residents and learners know that this is what you're giving. And most of us are giving feedback all the time, but maybe not quite, maybe not labeling it as such. You're also going to be wanting to link it to objectives. So we talked about the 99 priority topics or other objectives for other schools and programs, if it's an undergrad program. And then finally, planning actionable steps. So we talked about not doing too much, making it so that there's 2 or 3 specific things that you want to do to take their performance to the next level. And I think that, making sure the learners know this in advance is important. So That's it.
And I think we're going to have time for a little dessert. Once you've given your feedback, how do you help your learner make use of the feedback? So one last little poll. Do you ask your learner if your feedback was utilized and useful? Do you do that sometimes? What about you, Blaine?
I think... Yes, I think we try. I think what we find out oftentimes is on our teacher evaluations. That's where you hear how, what they thought of the feedback and of working with you and all those things. But I think we could do more. I think if we structure it in our day-to-day, as giving the learner feedback and receiving feedback from the learner, I think that our learners are ready to give us feedback. And
sometime on a following encounter, you could ask.
Absolutely, yes.
Okay, so a lot of our audience do ask, so nice. So what next after feedback? Once feedback has been given and received, it is good teaching practice to help the learner figure out how to improve. If the learner is left without any guidance other than you have to improve this, or you should read on that, well, the learner can feel quite overwhelmed and even distressed. The first thing, if you sense that your feedback has triggered an emotional response, it's important to name what you observe and address it. If you're not sure how it is received, you can ask. It's important to listen respectfully and acknowledge that reaction. Here are some examples of statements that you can make to acknowledge and validate the emotional reaction. I can see that you're upset by what I just said. You're not the first learner to say that. It can be disappointing or upsetting to hear feedback that is different from what you think you're doing. And I remember that feeling, tired, overwhelmed, or overworked from my own residency. And if you do not address the emotional reaction, your learner might not be listening at all to your feedback and not using it at all. And then you can explore with the learner. But before going ahead and telling the learner what they need to do, it's important to give them a chance to find their own solution. It's a little bit like a motivational interview with your patients. If the decision on what they will change comes from the learner, it has a better chance of actually being implemented. So start by asking questions. What could you do different next time? What resources could you access to help you with this or that? How can I help you with this or that? And you can consider a mini learning plan by helping the learner figure out his own objective for the next encounter, and based on his self-evaluation and based on your feedback. And just to remind you, a SMART objective is specific, measurable, attainable, realistic, and timely. And avoid making too many objectives. This is not realistic. The learner will not have enough time to fulfill them, and you will not have enough time to follow up on them. Also remember that there will be many other opportunities to learn. Everything does not need to be taught in one encounter. And do plan to follow up on it at the next encounter or via email or any other way that suits your learner. We're almost there. Then you might want to help your learner build their toolkit. You might know of a really good app or website that you can recommend, or a good review article or guideline. You can share your repertoire of local resources and tips from your own experience. If you suggest reading, please suggest a specific article if possible, or at least try to be precise on what you want the learner to focus on. For example, instead of saying read up on headaches, you could say read up on the prophylactic treatment of migraine. And also, like I said earlier, plan to follow up on suggested reading, and that can be at the next encounter or via email or even text nowadays. Speaking of tools, let me remind you of those 2 tools that we discussed earlier from the section of resident that can help both you and your learner in giving and receiving feedback. And these tools are generally very well received by learners because they were made by peers. And you can consult them yourselves and recommend them to your learners. And the link is on the slide. One last word. Documentation is crucial. It's important to document your observation and feedback using the tools provided by the program, field notes, e-portfolio, etc. And this will be very useful for the end of rotation evaluation to make sure this evaluation is based on facts and not on hearsay. Some teachers are often worried that a negative comment on a field load can lead to the failure of a learner. But if the learner only had one bad day, then all the other field notes will be fine, and there will not be any terrible consequence on the learner. But if it's behavior that happens repetitively, well, it will show up on field notes, and then the competency committee will have material to make a diagnosis and put a learning plan together to help the learner achieve competency. And the earlier that diagnosis, well, the better for the learner. And if you do have a major concern with a learner, you should contact the person in charge of the rotation or the program director for support. And if you do have to contact the person in charge, well, you should inform your learner that you will do so. And now we have a few minutes for questions.
Great.
So we'll see the questions showing up on the screen anytime now.
Okay. Good. Well, hopefully they won't be too difficult.
Hopefully. Any difficulties you encounter with giving feedback?
I guess, it's sometimes finding the words. We say use neutral language. It's trying to get across what it is you think that the learner needs to do between the gap of what they're doing and what they need to do, and finding the right words to say that.
Okay, here are some questions.
An example of a field note.
Est-ce qu'on utilise le modèle ortho également? Le modèle ortho ressemble beaucoup au modèle SNAPS. Oui, c'en est un qu'on peut utiliser, mais je ne l'ai pas sous la main en ce moment, fait que je ne pourrais pas vraiment discuter ça. May I have an example of a field note?
Maybe at the end of the presentation, I don't know if
I don't know if we can attach this to the presentation.
Yeah. I mean, it's kind of, it's stating our
what
field
went well,
notes. Yeah.
What could be improved, and sometimes with a sort of a prescription for what what can you do next?
Yeah. And sometimes learners write these themselves. It may not always be the teacher that has to write them, so that the learner can decide what it is they would like to read up on or research.
If you're told that your feedback was not well received, how do you deal with this?
So we started to talk about that.
Yeah, acknowledge the emotional response. And sometimes you can agree to disagree. Sometimes it's just, well, I'm going to write it down because this is what I observed. You might not agree with this, and it's okay.
And maybe looking at what were the circumstances that led to how you gave the feedback. Was it in private if it was constructive feedback? The type of language, what the measuring it against the objectives for what we had hoped for the rotation or for that particular half day. I mean, lots of times we, at the beginning of our clinic, will say to our learners, what would you like to receive feedback on today? I'm going to watch you a little bit and so on. Do you want to, and set it up so that they know
success.
it's coming. Yeah.
Well, that one is for our technical support. Where will this webinar be posted for sharing with other teachers? If you go to the CFPC website section of teachers page, you will find links to all the past webinars, including this one. How do you deal with students that have difficulties to receive feedback? Well, that's a very that can be seen two ways. I think there are some residents who just close up, and the other that just don't agree with our feedback. But some just really don't. There always are argumenting or finding reasons.
What ifs?
Yeah. How do you deal with that?
So again, these are delicate conversations to have in private. I guess laying out the facts of whatever it is you're discussing in the feedback. Did you observe this yourself? Was it someone else who's giving you this information? If it's hearsay, it's obviously not something we want to discuss. And then sometimes, if it's a learner and they're off maybe in their thinking about perhaps a diagnosis, and they're giving me information and they're trying to put a case together for a particular illness, and it's not quite fitting with what I think and what the typical presentation is. I'll say, well, tell me what the typical presentation of whatever is, and then we try to see where the gaps are in terms of, okay, well, if the typical presentation is headaches, fever, and whatever, and they don't have those pieces, then you could say, okay, well, maybe that's something.
So basically, it's comparing against benchmarks.
Exactly.
Or against what's the average student of his level should be doing.
Absolutely.
One last question, because I think it's a good one, and I'm sorry we won't have time to answer everything because time is running. Would you agree that proper feedback can be an excellent way to promote self-assessment, which we all need to do throughout our career? And the answer is a big yes, of course. And I think it's important in our teaching facilities to create a culture of feedback by being open to receive it ourselves, and making it like this is a normal part of lifelong learning.
Absolutely.
And you need that to move on and like I said, to change the culture and make it something that's not threatening, but that is a normal part of every day.
Exactly. If you set it up that way, if you have your huddle at the beginning of your clinic, I'm all about giving feedback. This is my approach. Ask them, do you want to use the 1-minute preceptor? Is there another model that you've used that's worked? How can we make this so that this, you have to go home at the end of the day looking up something. I tell them, if I go home at the end of the day and I don't have a question, if I don't feel like I've got to look something up, I'm really not keeping my own lifelong learning going. So that's my approach, and I tell them that. And then when I give them homework or give them feedback, it's anticipated.
Will a list of all the resources and websites from the presentation be made available after the presentation? Well, they're all in the presentation, and yes, you will find it if you follow the link on the page of the section of teacher. And that's all. We're done.
Great.
Thank you very much for your attention and for your very active participation and interesting questions. And please complete the evaluation survey by following the link in the chat box. And we need this feedback to improve and continue to provide useful and relevant faculty development webinars. Thank you very much.
And thank you, Lynn.
Thank you, Vina.
Great.
Goodbye.
Bye.